everyone. I am thrilled to sit down today with Dr. Ken McClain, Dr. Carl Allen, and Dr. Jennifer Picarsic, who are clinicians and researchers and pathologists with a passion and focus on histiocytosis. Dr. Ken McClain is the director of the histiocytosis program at Texas Children's Cancer and Hematology Center and member of the leukemia and lymphoma programs. Dr. Allen is the associate professor of pediatrics at Texas Children's Cancer and Hematology Center. He is the co-director of the histiocytosis and lymphoma programs at Texas Children's. Dr. McClain and Dr. Allen see 150 newly diagnosed patients with histiocytic disorders each year and follow more than 1,000 active patients, including from 5 continents. Dr. Picarsic is a pediatric pathologist and co-director of the Histiocytosis Center at Cincinnati Children's Hospital and Medical Center. Dr. Picarsic is helping to lead the field in the diagnosis of LCH, histiocytosis, and related diseases. Congratulations to all of you on your recent publication, Circulating Senescent Myeloid Cells Infiltrate the Brain and Cause Neurodegeneration in Histiocytic Disorders. Now, neurodegeneration is very important and I feel is an under-addressed topic on the patient side. So I was really eager to connect with you when I learned about this publication and look forward to learning more about the key findings, the importance of this work. Matthias Wilk and Miriam Murad were instrumental to this work and publication, so I also wanted to give them a special mention as authors on this paper and look forward to sitting down with them in the future to hear their thoughts as well. I know this is quite a collaborative effort, and that is always very exciting to see. So without further ado, let's dive into the background of neurodegeneration and how your work collectively is advancing the field and talk a little bit more about the importance and significance of this paper. We'll start with you, Dr. McClain. Would you please share some background on neurodegeneration, neurodegenerative LCH, and set the context for the importance of this research?
I think that the story of how LCH affects the brain is a good parallel of what's happened in the Histiocyte Society over the past several decades. And it kind of begins sort of maybe 20, 25 years ago when Nicole Groys and her colleagues in Vienna began gathering MRI images from patients all over Europe and the United States too, who had changes in their brain. And they found that patients with these changes often had problems with bone lesions around the ear or eye or the jaw, and they often had pituitary involvement, and they kind of developed this concept of CNS risk, quote unquote, lesions where there was a higher chance that LCH is going to affect part of the brain, and that might be just the pituitary or it might be other parts of the brain. And through a Herculean task, they looked at over 80 or 100 images, brain images of patients, and put together a list of places in the brain that were affected by LCH. And they found that a lot of these patients who were having problems with walking and speaking and intellectual issues had lesions or abnormalities of the MRI in their back part of their brain, the cerebellum, and also in the brain stem, which is where brain is connected to the spinal cord, the pons and the basal ganglia and other sort of central parts of the back part of the brain. And the term neurodegeneration was developed to kind of encompass all of these patients who had these MRI lesions, plus those that had the MRI lesions and the clinical findings of all the problems I spoke about. And that's been one of the hot button issues that I think has scared so many parents and patients for a long, long time, because you can have these abnormalities in the brain MRI, but not be clinically affected. So in other words, you could have some T2 or flare images that are abnormal in the brain, but yet you can walk and speak and think and exist in the world just fine. So I think that's been one of our missions, is to try to more clearly explain the differences between these two categories of patients. And early on, there was very little research in this problem, and there were very few biopsies available for investigators to look at. And besides the lack of material, there was a lack of reagents to investigate. And I think that's one of the really amazing parts of the story that we're going to get to, is how the new tools that we have allowed us to expand our knowledge so dramatically. Because back 20 plus years ago, when Nicole and her colleagues looked at the brains of some of these patients, they only had a few stains that would identify different kinds of cells, and they did not see the classic CD1A positive histiocytes that we associate with LCH. They saw a few macrophages and they saw some lymphocytes. And so they thought the lymphocytes were really the bad actors here. And fast forward to now, we realize that's not the story at all. But I think that it's kind of a testimony to not only collaborative work, but to persistence by a lot of people to collect these patients, and for the families to willingly sign up for research studies, and for people to gather collaborators from very disparate parts of the scientific spectrum to bring expertise that allows us to make these advances. So I think historically, it's really a fascinating story. And like so much of medicine, we do the best we can with the tools we have, and then new tools come along and we're in a much better place. So I think there are a lot of things that at play here. It's not only discovering the biology better, but now we have better therapeutic tools, the inhibitors and some of the other medicines that we're using now are going, I believe, to help us help more of these patients.
From a diagnostic perspective, what would you like to kind of talk about in relation to the publication or just neurodegenerative LCH?
Yeah, as Dr. McClain had mentioned, the lack of biopsy material has really hindered our full understanding of this disease, because this is it's an interesting disease in that it's a cancer, but it's a sort of neoplasia of inflammatory cells that draw in a lot of other inflammatory cells. And we didn't know at the time, when all of the tissue, the few samples that were tested in the old Groyce days, we didn't know about the BRAF mutation at all. So we weren't able to fully test those samples. And Dr. McClain said the biopsies rarely will have the diagnostic CD1A longer-in positive cells. And what was noted in those studies with a few cases was that there were these accumulation of macrophages. And, you know, I would love to be able to go back and test now to see, but we do believe that those macrophages, a lot of the cases in BRAF mutated cases are probably mutant. And what we saw in this paper was that it wasn't necessarily the CD1A and longer-in positive cells, but the mutated histiocytes that had a macrophage phenotype. And with the ability to look at a rare autopsy case in which we were able, through the generous donation of a family and a patient that was willing to let us review their brain for research, we've gained an incredible amount of knowledge. I mean, that gift has really been able to take what we think is going on in the mice and then show with true demonstration of the end stage, because a lot of the problem is with the mouse studies, it can be hard to get to that long stage. So what we see in the human form is, once we're able to see it even under the microscope, it's at a very late stage of the accumulation of these mutant cells at the site. So having the mouse study to show the beginning parts, and then that human brain sample to see the end parts, we were really able to take the arrows and really line them up. So instead of having a dashed line, we were creating a little more solid lines to understand that. And it's a fascinating disease in which these mutant cells, because they're mutated, they're still bringing in a lot of inflammation. And so what we think is happening is that these mutant cells do destroy or make this blood-brain barrier, which should be a very tight seal and not letting any cells in. When it is through this inflammatory process, the mutant cells are able to come in and infiltrate into the brain. And then having that collection of cells in the brain in a very important sites can cause, it's almost a sort of scarring. So it's not so much like a tumor, a large cancer, but these mutant cells that are creating more inflammation to the site. And then that causes sort of little scar type tissue, what we call gliosis, in those areas. And then that's what leads to the chronic debilitating changes, diabetes insipidus, the other white matter changes in the brain. So we're seeing this interplay of both a cancer-like property of inflammatory cells that then leads to more end-stage injury with a fibrotic type process happening in these critical sites in the brain.
Yeah, I mean, I think that this paper is really really exciting. I think for all of us, and it represents, I think, as Ken said, a lot of the sort of indirect collaboration from the field, from Dr. Groyce and others who really pointed to the problem of neurodegeneration. Barrett Rollins, who discovered the BRAF V600E mutation, and then we've been working. Jen and Ken and I have been working with Mira Murad's group for probably 14 years now to kind of figure out, the mechanistic implications of this BRAF V600E mutation in certain types of blood cells. And back in 2014, we showed that if you put BRAF V600E into blood cells at different stages of differentiation, you get kind of different types of LCH. And if you put it into a very early blood cell, you get a disease that looks a lot like high-risk LCH. The mice get big spleen, big liver, their bone marrow gets infiltrated, their lungs get disease. And they get this explosive disease and die at about 2 or 3 months typically. And we always wondered, well, could this model be used to sort of demonstrate neurodegeneration, or how does neurodegeneration work? And we had a clue when we were working on a project with Jen about back in 2018, when we were looking at blood of patients with LCH and patients who developed neurodegeneration and patients who didn't develop neurodegeneration. And we were able to see at very, very low levels, but we were able to see kind of repeatedly patients who ultimately developed neurodegeneration maintain BRAF V600E detectable cells in their circulation, even years after they were presumed to be cured from their systemic disease. And then that's where Jen did some really meticulous imaging studies of the brain and showed that, in fact, BRAF V600E cells are concentrated around blood vessels in the brain. And this kind of gave us indirect evidence that neurodegeneration isn't a paraneoplastic phenomenon needing a reaction, like an immune reaction to cancer. It's not an autoimmune disease, but really it seems like it's kind of a brain-specific version of LCH that just presents in a different way. But this observation was sort of indirect, and it was an association. And I think what this paper demonstrates, it's sort of mechanistic proof that one can develop, you can, if you put BRAF V600E cells into or BRAF V600E mutation into very, very early blood cells, not only do the mice develop systemic disease, they can develop neurodegeneration. And we were able to discover this because Matthias Wilk, who's just a brilliant physician scientist who was just sort of, I can't express enough how much sort of thought and work and sweat and bench time went into this project. If anyone has a chance to read the paper, you'll see all the amazing work that he did on this. And he really did every single study in this paper. But what he did that was so clever was to say, okay, well, these mice are dying very, very early of systemic LCH. What if we just take a few of their cells and transplant them into a healthy mouse. And so if you put just a few of these cells into an older mouse, you can kind of delay the kinetics of the systemic disease. And by doing that, we were able to see that, over a period of a couple months, these blood cells actually make their way into the brain, and they kind of transform into within the blood vessels around our brain. We have various different kinds of immune cells, and there's certain types of macrophages. And it's kind of serendipity that one of our friends and collaborators, Florent Gino, who's at Paris and Singapore, had just several months ago discovered this novel population of macrophages that live in the brain circulation called CD11A positive macrophages. And it's one of those things where Matthias was talking to Florent about this finding, and we were able to look and say, well, what different kinds of macrophages exist in the brain in these mice. And in fact, having BRAF V600 mutation really drives the CD11A population. This seems to be the Trojan horse that somehow, when these cells get activated, they turn into sort of a certain type of behavior where they become a bit inflammatory. They're able to break through the blood-brain barrier and establish residence in the brain. And this is really the truly fascinating finding. When you look at the infiltration of these CD11A macrophages in the brain, it really mirrors almost exactly the human condition. And then further, to get your original question about treatment, what Matthias was able to show is if you treat these mice with BRAF V600 inhibitors or other MEK inhibitor, as well as with a drug that kind of disinhibits resistance to cell death in these cells. So these cells become what we call senescent, meaning when cells become stressed, they kind of stop, drop, and roll, and they become really resistant to cell death, where normal cells would die from certain stresses. And so by using a MEK inhibitor plus a drug called navitoclax, which kind of blocks this apoptosis resistance, he's able to prevent these mice from developing neurodegeneration. And so I think this is something we really want to test in a clinical trial, because frankly, when we look at BRAF V600 inhibitors and MEK inhibitors, they don't seem to work as well for neurodegenerative disease as they do for systemic disease. And that may be due in part because of some brain damage that's established and is irreversible, but I think there's also probably something different about brain disease. I think the other thing that's really exciting about the study is it suggests, it kind of shows that if systemic LCH and brain LCH come from the same clones, but they just sort of have different kinetics and different pathways, are there certain biomarkers we can look at to kind of predict risk of patients who could develop neurodegeneration, so we can follow them more closely with MRIs and treat them before they develop clinical symptoms of LCH. And so I think really the sort of risk stratification and potential for prevention is probably as important, if not more important, than the potential to treat patients who have established disease. Yeah, I think this really represents, I think, one of the major clinical challenges. I know that, when we tell patients that their children have, 5 to 25% chance of developing some kind of neurocognitive issues, I think that's really scary. And now that we have a little bit of a foothold on what causes this, I think we can really start to dig in and understand the mechanisms better and find better ways to prevent and treat this condition.
Thank you so much. It's certainly very exciting to know that we have this information, and then as Dr. Picarsic mentioned, just the validation of what you had thought was happening, being able to really truly understand to that level. And Dr. McClain, since you have walked through the history for us of neurodegenerative LCH, is there anything else that you'd like to share about what you see this holds for the future? Anything else that you think the histio community would be interested to know?
Sure. I think it's important to reemphasize that just having abnormalities of the brain MRI does not mean that your child is going to have problems in school and not be able to play sports and have poor speech. So there are many patients that we see in our clinic who have MRI changes, and they're doing just fine in their day-to-day life. But so what it takes is careful follow-up and examining the children with detailed neurologic exams to see if there are hints of problems. And if there are hints, then we should be thinking about treating them. with drugs that will help them. And right now we have the MEK inhibitors and we have chemotherapy that we can use jointly. We don't know yet if that's going to be the best solution, but it's something we're trying. But there are probably other drugs, and as Dr. Allen mentioned, the drug that makes these cells more sensitive to death by a drug. When we get a type of drug that will do that safely in children, I think that will be something to try. It's a bit of a challenge now because that particular drug is a little toxic, I think, for kids, and we haven't really bridged the point where we want to use it. But I mean, we know a direction we should go, and I think that's very encouraging, and I think it gives us hope for helping more people more quickly.
Thank you. Is there anything that anyone else wants to share?
I thought one of the most fascinating part of this study is that among the many brilliant things that Matthias did was he found a way to measure the movement of the mice. And so there are some really outstanding pictures in the article showing how normal mice move around a cage, and there are all kinds of lines. It's just like, the cage picture is just filled with lines, but these mice who are sick aren't moving very much. They're sitting in the corners, they move with poor coordination. And then when you treat them with these two drugs, suddenly their movement looks like the normal mice. So I thought that was brilliant. It's really it's just such a graphic demonstration, and so easy to see and understand. So I found that to be a particularly exciting part of the paper.
I guess I just like to echo, I think what both Ken and Jen kind of mentioned about acknowledging the families and their, one of the great things I think about this community is we're all kind of looking for answers. I think, progress in LCH has been more challenging than other conditions because it's been a little bit of an unusual disease, right? It's like a lot of other things, but it's so unique. And I think that's why it's so gratifying as clinicians and scientists and as part of this community to be able to contribute to making steps forward. And I think, as Ken mentioned, so many people around the world are thinking about these children and adults and kind of working towards solutions, and we're all kind of building on each other's discoveries. And when you go to Histiocyte Society and other meetings, I think a lot of these ideas come from coffee break discussions, emails about, I have this one patient who had this condition, et cetera. And again, there's too many co-authors, I think, to mention on this that really contributed to the final work products. But Marcus Mann, Sergio Lira have been part of our broader collaborative group. Matt Collin, Florangino, a lot of the discussions at the Nicholas Symposium have sort of helped to frame this. And so I think this is just one more piece in the discussion that will, I think, continue with robust debate and science. And but I think in the pace of discovery is so much faster now than when I first got in this field. It's exciting. And I think turning all of this science into clinical trials and cures for patients, I think, is tangible, and it's something that's not just an abstract thought anymore.
Thank you so much. I agree. It is really an exciting time, and the collaboration is not only encouraging for those of us at the association and the other advocacy groups, but also for families to see so many of you working together really brings them so much hope. And the pace with which we're learning information is partly because of the collaboration and just the advancements that you have all made possible over the years. So thank you for taking the time to sit down and have this discussion and to share more about it. And I'm excited for everyone to also be able to read the publication, and if they have questions, maybe can reach out for more information.
I just want to emphasize that so probably didn't do it enough because it's so implied, but Mira Murad is the senior corresponding author in this study, and is her seminal discoveries in dendritic cell biology and continued support of LCH research and mentoring a lot of the great discoveries have been from postdocs that she's mentored. So I think we'd be remiss if we didn't make a special effort to acknowledge her leadership.
Thank you.